Hey, Bach. Welcome to our fourth AO Hot Seat. My special guest tonight is Bach Lee. My co-host, Ismail Cooley, is actually stuck in some very bad weather in Miami and is unable to pull his car out of some huge puddles. So I'll be helping you out tonight, Bach, and it'll be me and you. So before we get started, I just want to give you an introduction. We'll go right into it. Dr. Bach Lee completed his specialty training in oral and maxillofacial surgery at Oregon Health Sciences University and is currently clinical associate professor at the Herman Ostrow School of Dentistry at USC. Dr. Lee has authored over 21 chapters in textbooks on bone regeneration and dental implants and has published extensively in peer-reviewed journals. Dr. Lee was inducted as an honorary member of the American College of Prosthodontics and is a recipient of the Charles E. English Awarded Clinical Science. He's a diplomate of the American Association of Oral and Maxillofacial Surgeons and holds fellowships in the American College of Dentists, the International College of Dentists, and the International Association of Oral and Maxillofacial Surgeons. So welcome tonight, Bach, to our fourth AO Hot Seat. So,
hi, Bob. Yeah, it's really an honor to be here and really a lot of fun to talk about implants and the topic that we're going to talk about. So I'm really excited.
Great. I'd like to start out with a two-part question. So I'll say the first part immediately here. Can you share your journey from being a refugee from Vietnam to becoming a surgeon specializing in dental implants and mentoring many students in USC? We've talked in the past about this really episode in your life that got you here. So can you please explain this to the audience to get a feel as to who Bach Lee is?
So anyways, my journey, I'm a refugee from Vietnam, and my journey is really not any different than many of the refugees that have come over here to this wonderful country. I came here after the fall of Vietnam. In fact, actually on the day that Vietnam fell, and we left by sea and went out to the ocean, and we were rescued by the U.S. military, and we went to Subic Bay in a camp there, and eventually we made our way over the U.S. To here, California, Camp Pendleton, and we were just so fortunate to be graciously sponsored by beautiful family who give us material support, spiritual support, and allowed our family to really get a foothold and start. Forever grateful to those families that did that. And so both my parents, were professionals in Vietnam, but they, had humble beginnings here. My dad worked at Jack in the Box. My mom is a janitor. And that's how we started. Both my siblings went into healthcare. My sister's a medical doctor, my brother's a dentist. And so I just kind of followed in their footsteps in seeing what they did. And I fell in love with dentistry. I love, as all of us dentists, we love to work with our hands and the artistic nature of it. And when I finished dental school, I still couldn't get enough. I just loved dentistry. I could have gone into pros, perio, any of that. I just felt a desire to go and study more. So I pursued surgery. Went to medical school and dental school. And when I finished, I had this calling to go join the faculty because I really wanted to share the knowledge that I've learned and also continue to learn. So I joined the faculty at USC, where I served as co-director for the residency training for a number of years. I still am on faculty there. And, the rest is history. I got put together, to run some CE courses. And so I got involved with implants early on, many years ago. I was director of about 8 courses at USC. So that really allowed me the opportunity to kind of start early with education in implants. And so I've been really forever grateful for that opportunity.
You have children, Bach?
Yeah, I have 4 children. The youngest ones are just still in medical school. And so they're still, working their way through. So family life is busy.
We talked about balancing our lives. How does Bach Lee balance his life with work and family?
Boy, Bob, that's That's a tough question. I don't think that anybody, Bach Lee or anybody has the answer to that, but it's a juggle. It's a juggle that we all face. I personally have a very supportive family, and most of all, a very supportive wife. My wife really allows me to be able to do a lot of things that I do. And, dentistry for me is a hobby. She gets to do the hard stuff, taking care of the kids and making a wonderful home that I can come to. I really try to, to compartmentalize all the things that I do, work. And then when I come home, I try to put work behind me and spend as much time with family. It is it's always an ongoing struggle to do this. I get invited to do to travel and speak. And what I've found over the years is that you can have it both ways sometimes. So I usually don't go anywhere unless I can take my kids. So my kids have had the opportunity to travel, to a lot of different cool places because of that. And so that's how, we try to keep the balance. Is that,
That's terrific. Yep.
Yeah.
So let's go a little dental here. So what surgical procedures do you typically perform within your scope of oral surgery and maxillofacial surgery?
So, I've been faculty now. It's hard to believe, but we're going on 24, 25 years now at USC. And when I started, I worked full time at the hospital. As I said, I was the co-director of the training with Dr. Yamashita. So I did full scope oral surgery, and I still do pretty much full scope oral surgery. The procedures I do involve trauma, pathology, implants, pretty much the full scope of oral surgery. And I'm fortunate to be able to do that being in an academic center. I think that a lot of oral surgeons, once you leave the training and the academics, it's really all just wisdom teeth and implants. But being in academics really allows me the opportunity to really be in the forefront of what's going on and to do a lot of the fun stuff that is in the full scope of surgery.
And really keeping abreast of everything new, which is great about being in teaching as well.
Yeah.
So how do you approach translating large surgeries as you do in oral maxillofacial surgery into the microsurgical techniques that we do daily around dental implants?
That's a really good question. And I think that that's the area where I struggled in the beginning. As I said, when I started at USC, it was just by coincidence that I was asked to do CE courses. And so some of the CE courses that were popular then was implants. And, coming from an oral surgery background, most of the things, I went into oral surgery, and most oral surgeons like people that go into surgery like immediate transformation. We like to see the before and after, right? You resect the tumor, you see it immediately. You do orthodontic surgery, you see the immediate and the before and after. Implants is a completely different, it's not this immediacy. You're almost in, because when we take out a tooth or we put in an implant or we do a bone graft, we have to wait. And before we see the immediacy or before we see the result. So in the waiting process of taking out tooth, you see bone resorb, you see tissue recede. And during this waiting period, what I've learned is that there are really a lot of subtle changes that occur in implants, particularly the aesthetic area. And so immediacy is not always the best thing. And I've learned to really embrace the concept of time is your friend, and that it is almost a deliberate slowing down of the procedure so that you can actually calibrate and adjust and sometimes do more surgery. And so from that standpoint, it's completely changed, the way that I think about implants and how I think about even surgery in general, that we're really just, this is a transient nature. Most of the procedures that we do, I look at it that, we're kind of borrowing time. We're transient in this one segment of time, and that the clock keeps on ticking. And so what we do today does change over time. And so it's nice to slow things down and let things settle. So
let's talk about a single missing tooth in the aesthetic zone. We'll start with the single tooth category.
Mm-hmm.
How do you prevent the complications of everything we could think of when it comes to complications with the aesthetic zone, loss of papilla, loss of ridge height, and everything else that we could think of.
Yeah. So, the way I try to prevent that is create volume, right? So when we talk about most of the complications in the aesthetic area, they're really a loss of volume. So you're either losing horizontal volume, vertical volume, resulting in recession, or a loss of papilla. So I always go back to dental school. The first day of dental school, we get a ball of wax. We're given and we carve the wax into the shape of whatever we want. And so this is the part of dentistry that I really love, and is to be able to carve this aesthetic tooth and to frame this tooth through the architecture of the tissue. And so how do we do that? Well, we do that by creating volume. And so that's my goal whenever I do this, whether it be in bone or soft tissue. So let's just take a single case.
Why don't we get our first slide up? Yeah,
let's put the first slide up. So, I always want to create, what I always say is I always overcorrect to what I call a thick and high crest. So it's essentially the situation on the right is what you want. You want a high crest. So in other words, there's coronal bone, which then gives you coronal soft tissue, and you want a thick crest. So horizontally, it's thick, and then it's high. So we don't want anything on the left, right? Obviously. So now that's my ball of wax. And now when the implant goes in, we can actually carve and sculpt the soft tissue into the tooth shape that is ideal for the site. So now the reason why I always try to achieve this, and this is my goal whenever I graft or approach an aesthetic case, is that most of the surgical procedures we undergo resorptions. We talked about time is your friend. There's not a procedure that I've seen that doesn't undergo some type of remodeling or resorption. So I always want to have too much bone and too much tissue. So anytime I go in there, I do so I talk about calibrating. So I often go in and calibrate and add more bone or tissue. So I'll share with you a number of cases kind of illustrate this. First case is a very straightforward, simple case. So you have a young girl that's going to lose a central incisor. Typical situation that you see in a daily dental oral surgery practice and perio practice, right? You got a tooth that's failing. You're going to take this tooth out. It's number 9. You got a fistula. It's had a previous apicoectomy. And so we take a CT scan and you see the bone loss. And if you just only take the tooth out and do nothing, of course, you're going to have collapse of this area, resulting in a crest that's deficient. The key, I think, I want to share with everybody, and I know there are many approaches to do an augmentation of a procedure, but I think the most important aspect for me and how I am able to achieve this thick, high crest, this ball of wax, is the incision design. I make a very limited incision that is localized to the site. So I make a vertical incision localized to the site that I want to correct. So let's say this area, I want to overcorrect this area. Most people will make a vertical incision that is distant, one tooth away. But I like to make it to one vertical at the site following the mucogingival junction. And by doing this, I'm able to localize and maintain my graft and overbulk that area. And if vertically, I need to grow the bone vertically, I can do that with this incision. So the graft can't migrate apically. It has to stay exactly where it is. I often call this the open book incision. It looks like I'm opening a book. And so it's graft containment, and I can advance the gingival margin. So when I put the graft in and when I close it, the graft can't go anywhere except for coronally because it's bounded by borders. Apically by the nasal floor, the nasal spine, and then laterally by the tunneling. So it can't go anywhere. So it can only stay there. So by doing that, so here in this particular case, I make an incision and then I overcorrect. So the incision allows me to, you can see by that vertical incision there, I can overcorrect vertically and horizontally. Then when I close this incision, I leave it exposed in this area, which a lot of people, this is not anything new, right? You leave that exposed and to granulate keratinized tissue in. And so what you see is that the tissue migrates coronally because the bone is contained in that site. And you can see the before at the time of suture and then at the time 4 to 5 months later. Now, inevitably, you almost always see this if you follow this protocol, so long as you don't impinge on the soft tissue. You and take a photo of the cases, and you always see this. So this is that ball of wax. Now you have too much bone, too much tissue. Very straightforward. And now it's just really a matter of implant placement. And so how do you maintain soft tissue and papilla? That really comes down to when you have this ball of wax is implant positioning. And so you can see the bone is coronal to where it was previously. So you can see before CT and after CT. Now, to get tissue thickness, it all comes down to implant positioning, almost 99%. And so I place most of the implants I place, I do in a flapless fashion. I must place it deep enough to create vertical soft tissue thickness. The positioning of the implant is extremely important to create that. So if there's a healing abutment that's 3 to 4 millimeters, it's got to be at least flush or below the gums to ensure that there's at least 4 millimeters of soft tissue thickness vertically. So, we've studied this, and we've looked at implant angulation and positioning, and as it relates to tissue thickness. And when the implants are angled at different angulations, the tissue it is correlated with tissue thickness. So in patients that have 2 implants, if one implant is angled towards the cingulum and the other implant is placed towards the buccal, it's almost twice the thickness of the tissue in the same patient. So based on the study that we published. Same thing in an animal study. We found that by placing implants either in the center, the buccal, or the palatal, if you place the implants towards the palate, you have more bone, but that translates to more soft tissue also. So following that protocol, and then also that's horizontal thickness. Now vertical thickness is based on the vertical positioning of the implant. So for example, here, if you look at this case we did in 2006, we placed 3 implants. One is supracrestal, one is crestal, and then the third one is subcrestal, below the bone. And you can see the vertical thickness of the 3 different sites. Obviously, you want the implant, the tissue thickness on the right. So thickness is, in tissue, you have horizontal and vertical. So by placing it, by respecting the angulation and the palatal buccal position, you maintain horizontal thickness, and depth, you maintain vertical thickness. So going back to this case, we angle it towards the cingulum, we place it deep enough and palatal enough. Now we have the volume of tissue. Now it's that ball of wax. Now my prosthodontist, who's a wonderful prosthodontist, Dr. Gianmarco O'Brien, he very artistically sculpts the soft tissue with his provisional. And this is not, in fact, well, it's actually very, 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 very technically challenging to do because you have to kind of add enough to displace the tissue apically. So he adds the tissue, and then, this tissue is allowed to kind of settle after 3 months. And then our lab technician, Naoki Hayashi, makes the veneers and crowns for the other 3 teeth, and that's the final result. So in essence, we control where that tissue margin goes, and we create enough tissue height that we can sculpt it. So we're in control of this. Now, if you look at the CT scan of this case, prior to doing this treatment, the tissue was only 1.5 millimeters thick. So I'm going to go back and just show you. If you look at the tissue thickness on the CT scan, and I forgot to point this out, you notice that the tissue on this case was only 1.5 millimeters thick when we started. Now, most people would look at this and say, well, you need to do a connective tissue graft. But as I told you, implant positioning, I believe, is a really strong indication, is a strong, can affect this tissue thickness significantly. So let's go back to now, afterwards, once the implant's in and the restoration, you can see the thickness of the soft tissue is now 3 millimeters, 3.5. It's almost 2 millimeters thicker than it was before we started. So you can
comment back regarding this.
Yes, go ahead.
Yeah, the interproximal height of bone, which when I'm talking to residents, this is very key to do not disturb. Your incision design on the mesial 10 was perfect from a standpoint of not disturbing that at all. We need to keep away from that on all extraction techniques. But the way you overbuilt the bone vertically, you mentioned about tissue sculpturing. What about the bone sculpturing that you may do at the time of implant placement? What I would call like a bone, not so much a bone profiling, but really to level almost the CJ, so to speak, of number 8 and 9 in this case, so that you're positioning and giving the enough of the emergence profile. By bone scalloping is the word that I was looking for, scalloping.
Yeah. So, in over the years, I've really never had to go back in and scallop the bone.
No, at the time of surgery, though.
Or at the time of surgery. So this case, on this particular case, I actually placed the implant flapless. And you notice that when I placed it, there was too much bone.
Yeah. So
I placed the implant subcrestal. So I placed it deep enough that to ensure my vertical tissue thickness, and then I have to place it so that it's deeper than the gingival margin, so we can actually sculpt this. You're absolutely right. I don't ever go back and
for
profile.
the younger surgeons in the audience, how do you determine how deep is deep enough?
That's a great question.
Without a surgical guide. I mean, obviously you've got all these years of experience, but how do you relate that to your first year oral surgical resident?
Yeah. So the implant needs to be deep enough. So after you create that high crest, when you place the implant, you obviously have to judge where the gingival margin of the adjacent teeth is. Right. It needs to be 3 millimeters, at least 3 millimeters deeper than the ideal gingival margin. So now I typically will place it more palatal and slightly angled towards the cingulum.
Yep.
Because of that, I usually place it 4 to 5 millimeters deeper. So I will place it so every millimeter more palatal, I tend to go a little bit deeper. So my implants tend to be about 4 millimeters because I have more tissue to displace.
And that's even more important with a reduced diameter implant to make sure you give enough running room for your prosthodontist.
Absolutely. You need enough running room. So yes, so that's why you have to go even a little deeper. Now, having said that, that's really important that, and we don't want to get into this, but you want to make sure that the connection is that the implant choice has a connection that is tight and that does not leak. Because once you place these implants subcrestal and you have leakage, you have bone loss. And then you have a whole nother problem.
Yep.
So,
okay, thank you. All right, you want to talk about how you deal with multiple missing teeth? Also, is that coming up soon?
Yeah. So multiple missing teeth. We I follow the exact same principle. So we'll talk about single teeth, and now we'll get into multiple teeth. So let's talk about this situation here. So this young girl is going to lose all 4 of her front teeth. So that's 7, 8, 9, and 10. And so if you look at the CT scan, you can see she has, radiolucencies and in fact, some of them are through and through, both gone through the buccal and the palatal. She's got a thin bile type. So you can see on this, the clinical cases, you can see when you can see through the gingiva like this, where it's dark, it's less than 2 millimeters, right? So she's got a thin bile type, and she's losing all 4 teeth. So now that's a challenge because she has a high smile line. So all 4 of these teeth were were sent for extractions, and she had seen multiple specialists who told her that taking these 4 teeth out with these defect, it's going to be a problem. And so this is the rest of the CT scan. You can see on the right side, number 9, she's got an hourglass appearance of the ridge on both 7 and 9. So we know that when we take these teeth out, it's going to collapse significantly, resulting in a very difficult defect. Now, how do you handle a case of multiple adjacent teeth? Now what I want to share with the young residents and the young implantologists after 5 years of doing this, is that it's not a procedure, and it's not if you have a drill, you can drill a hole and put an implant in, but really how you think through these cases. And many of these cases have unique aspects of them that needs to be tailored. And we talked about earlier about how I do the large surgery and translating it to the small surgery, is that you have to calibrate these cases according to the needs of the case. So this case needs 4 extraction. Well, we know from science that if we take out 2 teeth, we have a bigger hole than we have 1 tooth. So Al Axgar showed in 2013 that if you take 2 teeth out, you have more bone loss than if you take out 1 tooth. So using this knowledge, why not just take out 1 tooth rather than take all 4 teeth at the same time? And so how I handle this is, I already showed you how I handle these cases. It's basically the first case. I just do it at one time. So I always use the analogy of bone is like money. When we have, when you have a lot of the cases where you have a lot of money, it's easy to make money. The cases where you have a lot of bone, it's easy to make bone. You have thick walls, easy to make bone. You have a lot of bone, it's easy to grow bone. But when you have thin bone, you don't want to take risks. When you don't have a lot of money, it's hard to invest and make money, right? So you need to make the money. So here, if you can see, I'm just going to take out only 1 tooth. So rather than take all 4 teeth out, I'll take 1 tooth out. Because if I were to take out this tooth here, number 7, and also take number 8, what do you think would happen to that little peak of bone?
Lose it.
Yeah, I would lose it immediately. Now I have a vertical defect. I've created a problem that it's unnecessary. I didn't need to do. So my goal is, I'm going to stage this. I'm going to make the bone to protect that little peak. Once that bone fills in, now when I take out 8, that bone, that peak of bone is protected by the surrounding bone. So I use the same incision design. So how do I prevent problems, and how do I, the question you asked earlier, how do I, maintain tissue and papilla? It's all about maintaining bone. So how do we do that? Well, we stage, time is your friend. As I said earlier, I stage extraction when I need to. I stage augmentation. I always use a Pontic, and the restorative plan is always either 2, 4, or 6 teeth. I like symmetry whenever I can. And so let's go back to this case here. We're going to take out 1 tooth. We use the same incision design, right? To correct to a thick high crest. Graft cover with
Bach, I'm sure some of the audience is thinking, why not deal with number 10 at this time as well?
Great question. This patient is from out of town, and a young patient and a high smile line, right? So remember I said about money. When I have a lot of money or whenever I have a lot of risk, I slow everything down. Yep. And so this is a message that I'd love to share with everybody, is that you don't need to do everything fast. And when you have high risk, it's okay to slow things down. The patient's already your patient. They're not going to go somewhere else. You want to, because if I were to do 7 and 10, and God forbid something happens at one of those sites or both of those sites, or at least then I have 2 problems to deal with. If I'm dealing with one problem here and I have a bad result, now I'm, a little bit more cautious in what I do rather than have 2 problems. So that's how I think about these cases. Whenever there's risk, I back off. I slow down. So you see where I suture at the gingival margin, and you see how it creeps down. And I tell everybody this: take a camera and document it. You will see that it's going to creep down to a higher crest. So now at 3 months, normally I would wait 4 months, but at 3 months, I saw that she's healing very well. So I go ahead and I do the other side. I didn't need to wait the full time. So I went in, I did the same incision design. I took out the tooth. You can see the number 9 needs to come out. You see the bone loss there. In this case, there was very thick bone on the buccal. So I placed an implant. I did a contour graft. I overbuilt over it and the membrane. And then I let that heal. Now, the reason why I do that and not take out the tooth next to this is for the same reason that I said earlier. When you take out a tooth next to another tooth, you have more bone loss. And this is confirmed by another study done the same year. This is an animal study by Favero. And what he showed was that you have more bone loss associated with an immediate implant if you extract a tooth next to it. So I always say in the aesthetic zone, never take out a tooth, or don't, I don't want to say never, but refrain from taking out a tooth next to an immediate implant if it is of high aesthetic demand. So here, I'm not going to take that tooth out. I'm going to make the money around the implant. Now, once that implant's integrated at 3 months and I have bone, then I go back and I take out those 2 front teeth. So I'm essentially calibrating. I'm slowing everything down to calibrate the bone that I can put in.
Bach, I got a question for you.
Yes.
Go back one slide, please, Jim.
Mm-hmm.
Are you looking at that width of the buckle? Yeah. Yeah, where you have it says immediate implant number 10 right there.
Yes.
Are you looking at the width of the buccal gap differently today than you did, say, when you did this case?
No, I usually want the gap to be about at least 3 millimeters, 2 or 3 millimeters. And that's about, and that's based, why do you ask that question again?
I mean, that was in our latest ITI consensus conference, was at least greater than 2 millimeters.
Yes.
So 3 is even better. So yeah, totally agree.
Yeah. So that study that I cited in the beginning that we did, there was a study we did in Japan. It was an animal model, and we looked specifically at gap healing, and we looked at a 1 millimeter, 2 millimeter, and a 3 millimeter gap. And actually, the 3 millimeter gap did the best. Had the most bone. So yeah, that's why I go for the bigger the better.
Yeah, our clinical study showed the same thing. So that's terrific. Good. Yeah. Thank you.
So now I take out 8 and 9. Whenever I raise a flap, I add more bone. So this has been something that I've done for 20 plus years, is whenever, because I've learned over the years that all bone resorbs, and even in health you have resorption. But even in people that have bone today will resorb as they get older. That's the same reason why people shrink as they get older. Yeah. You're losing bone. Everybody's losing bone. So I add bone. It's like retirement money. So.
What about the type of bone? Because I'm sure there's people thinking, is that
great question.
FDBA versus xenograft. There's qualities for both.
Yeah.
What is Bach's thought process on this?
Well, this really depends on where you practice, where you're from, what country, what region.
Well, you're from the country.
What company you speak
California.
For.
So let's talk about California.
Yeah. So, I'm a big fan of using a mineralized allograft. Now, I know there are people who like xenografts. Some people that say that allograft resorb too much. So, I like to use a mineralized cortical cancellus, a large cortical cancellus graft. We've studied this also, and we found that the larger pieces tend to stay longer. And you just have to build on top of bone, because bone takes many, many years to actually mature. It hardens within 4 to 6 months to a year, but for it to become cortical and dense and remodeling takes a long time. So during that remodeling process, that tends to shrink. So I like an allograft. There's no demineralized bone. It's all mineralized bone, and it's a lot of bulking, like overcorrect significantly. So here's the 3 months. It's exposed healing like before. Leave it exposed for keratinized tissue formation. And then once it starts the early keratinized formation, we put the provisional in. We do a screw retain provisional, and we're very aggressive with sculpting this. So this is screwed in, full contour. There's no babying the tissue, because we've got a lot of bone here. I'm not too worried about babying and doing it incrementally.
I think it's important, Bach, to the audience, also the young audiences. You cannot do this procedure with aesthetics and creating pontics, ovate pontics, or whatever type of pontic you'd like to use, without a screw retain restoration. Because the restoration will not seat all the way, and you'll be able to bring the screw retain right into position.
Absolutely.
You want to comment on that?
Yeah, the only way to do this, there's two points. I'm glad you brought the first point, is the screw retain restorations. As you screw in, you're pushing and you're displacing tissue. You're really displacing tissue out of the way. By cementing it, it's just going to bounce back, number one. Number two, you must anesthetize the patient when you do this. So you can see here, if you do not anesthetize, then you really have minimal effect on the soft tissue, because this hurts. And so you can see here how the tissue is inflamed. This one day after the procedure, you see it's swollen, and that's okay, because that'll settle down. So, but the patient has to be anesthetized, because we're aggressive with this, because there's plenty of bone here. And now you can see the tissue starts to settle. And as it settles, it starts to look and conform to the site. And so that's that ball of wax. So you can see, so this applies to dentistry in general, not just implant dentistry. So I always say, even if you're doing a crown and bridge, if you did a bridge in this area, you would still want your pontic to look like 8 and 9 here. Yep. And that's how you achieve that, is by doing what we're doing. We're staging it. We're leaving the exposed healing for the keratinized tissue migration, and we're waiting for that tissue to drop coronally. And then we use an aesthetic pontic to carve into the buccal, and it hurts, so you have to numb the patient.
There's a question, Bach. How do you provisionalize? How do you coordinate this with your team, prosthodontist?
So how I like to do is that whoever makes my final restoration makes my provisional, and the prosthodontist or the restorative dentist, we take a facial level impression, send it to the lab, or we digitally plan it. But I'm so fortunate. I work with phenomenal lab technicians. So Naoki's phenomenal. He did this work here. So there's really not a whole lot that I really need to instruct him. I find that the biggest challenge that I have is when I work with inexperienced labs or inexperienced doctors. Yep. Then you can make a beautiful case, and as you probably know, the cases can go to hell very quickly with a bad restoration. So my advice to the young clinician or the clinician who's very detailed oriented is to find yourself a very good lab, a very detailed lab, and if you're a surgeon working with a restorative or prosthodontist, that they are also very, they pay attention to the little details, or else the cases are going to not turn out as you like. So from there, and by the way, this is a lot of this stuff is published. This is the Journal of Aesthetic Restorative Dentistry. It's a special edition, so you can go online and download this for free because it's a special edition. And this goes over the steps of how to do all this here.
Good, thank you for sharing.
Yeah. So here Naoki makes and you can see how aggressive we are with the provisional, how it really carves into the soft tissue, right? And the reason why that it has to be a thick crest is it creates this thickness, and then you have to carve buccally into it. So this hurts. That's why we have to anesthetize. Describe
your type of pontic you're using here. I know
this is called this pontic is called this is an aesthetic pontic. Now for the implant, Naoki uses what's called the edge. So he creates an edge right at the lip of the buccal-gingival marginal, inside the marginal tissue, to create this kind of this lift here. And so so it's just an aesthetic pontic design. And so you can see the bone volume up here. And this is what creates the tissue and the placement of the implant in the right position. So these are pontics, and they look like they're very good. They have good emergence profile. There's a lot of bone thickness. So that's how we manage that. Now there are cases, as you know, these are cases where you have teeth. Now sometimes you don't have teeth, and as I said, every case is unique. And I share this case to show you that, we could have taken all 4 teeth out, but a lot of times it's how you plan the case. And a failing tooth, and I've heard this said somewhere, I didn't come up with this term, but a failing tooth is not an useless tooth, right? You can use a tooth, you can use a failing tooth, you can use, parts of the tooth like socket shield and root submergence. So every case is unique in how we approach it, and it really depending on the needs of the case.
And the virtual planning is really the key.
Yeah, the virtual planning.
Virtual planning. Yep.
Yeah, is the key.
So let's talk about complications. Looks like this is one here.
Yeah. So complications. So as I was saying, every case is unique, and of course there's complications. This actually is a trauma. This is actually a young.
What are the most type of complications you actually see in practice, Bach?
What's that?
What are the most
common complications?
Common complications that you see in practice as well as at the hospital.
Well, when it comes to implants, of course, it's late failures. When you have late failures, it causes a tremendous amount of bone loss. Early failure, it's really the most common is graft failure or wound dehiscence. And I would say, I think with the popularity of biomaterial, I think everybody now wants to use the bone in the bottle for just about everything. So, when you have a hammer, everything looks like a nail. So that patient walks in, you see a huge vertical defect, and, it's everybody's just trying to do GBR because that's what is shown and everybody's doing. And sometimes when you put that into a site that has very little bone, remember I told you it takes bone to make bone. When you put these in the sites that don't have osteogenic potential, the wound's just going to open up to invite the material to leave. And that's why you see a lot of these wound dehiscence. So anyways, going back to what we were talking about in terms of like a tooth, a useless tooth you can use, or every site is unique. Earlier we showed how to deal with a single tooth, Bob, and then multiple tooth. Now, I just want to share with you, if let's say we were to have a significant defect with multiple teeth defect, how to manage it. And it's the same principle, and it's the principle of making that big ball of wax, right? So we got to, and it's easier to make that ball of wax when it's a single site, as I showed in the first case, and then the second case. The second case was multiple teeth, but I did it as a single tooth. So here you got a young girl who's she's about 20 years old. She fell down and avulsed the alveolar ridge. She took out the keratinized tissue around number 9, and she fractured number 10. And so here's the X-ray. So you can see that number 9 is completely avulsed with fracture of number 10. And now this is this is probably the most challenging defect, because you've got 9 and 10, and you're trying to match the papilla architecture of 7 and 8, which is very, very difficult. It's not impossible, but I would say extremely difficult. So we have to think uniquely of every case.
How old is this patient, Bach?
This patient is actually 19 years old.
Female. Yeah.
Nice smile line, gorgeous looking, beautiful girl. So this is the problem. So she's got an avulsed alveolar ridge, avulsed keratinized tissue, and unrestorable adjacent teeth. So you can see the trauma on the lip here. So what I did in this case, is I showed you how I managed those other cases. I always build on the foundation of how I do these cases. It's the same concept. I'm going to. So here's the defect. You can see there's a buccal defect, a palatal defect. She avulsed both buccal and palatal ridge, and the tooth is fractured here. Now, what if I were to keep this tooth? This is a patient that I saw, like I said, on a Saturday morning when the mom called. Now, as we said, a failing tooth is not always a useless tooth. So if I were to take this tooth out, so in oral surgery, a lot of times I would think, well, let's just take both of them out. But if I were to take this tooth out, what's going to happen to that peak of bone? It's going to disappear.
I'm sorry to tell you, but you're not an oral surgeon.
That's right.
You're a periodontist in oral surgery.
Perioral surgery.
Yes, exactly.
And I take that as a compliment.
It is a compliment.
So here you see the defect. So what I did is I actually just shaved the root down, and to leave the peak, and I actually used the root as a substrate to overbuild my graft over it. Now, so I overbuild the area. I put collagen, so building over that, and then I use the same concept as earlier, exposed healing.
And you didn't devitalize the tooth, correct?
That's a great question. We're going to get back to that. And what about this tooth? No, I did not I did not. So again, this is during a trauma situation.
Yeah.
There's a lot of evidence that a lot of these teeth. So in coronectomies, we take out teeth, right? When we're afraid of removing the roots next to the nerve, we remove the crown, leave the root.
Yep.
And, studies show that 98% of those cases, the roots remain submerged. Now, some of those do erupt, and the way you prevent them from erupting is actually you bury them with bone. And so if you bury them with bone, you reduce the incidence of eruption by about 3% more. So that's all we're doing here. We're just basically now, and then we build on the top of the concept of earlier. Now would it have been better if I root canal the tooth? Absolutely, absolutely. So here, I leave this exposed to gain keratinized tissue. And this is the beauty of this open book flap, is I can reposition this keratinized tissue next to the exposed area. So you can see at 2 weeks how it healed. It's granulating. And I don't want this mucosa over here to granulate in. I want the keratinized tissue. So at 12 weeks, you see the granulation. At 16 weeks, Then here's the implant placement. You see, I placed the implant, and you can see the bone has buried the root. And essentially, it's acted as a, so I didn't take the root out. It's completely covered. And anytime I go in and do surgery, I add more bone. And as you can see here, you may look at this and say, well, there's a ton of bone there, but you can never have too much bone, just as you can never have too much money, the analogy that I said. So we contour that, we wrap the keratinized tissue around that. And then this is 3 months later, we deliver the provisional. There are gaps and holes and black triangles, which I'm not too worried about. I let it settle. 4 weeks, you can see it settling down.
And this is a screw retained single unit with a cantilever.
Correct.
And that was one of the questions we had. All your provisionals are screw retained.
They're all screw retained. Yeah. They can only be screw retained.
Exactly.
Then you see the tissue is coming down. Even in the provisional, it's coming down coronally. Then because we pulled this frenum out, we did a frenectomy. And you can see at 12 weeks, it's coming down even more. This tooth is starting to look short now. Number 9 is starting to look short compared to 8. And then you see, the papilla is coming down.
It looks like you opened it up slightly between 9 and 10 at that point.
Actually, I didn't. The tissue keeps on coming down. If you add bone, the tissue will come down. It's going to, if too much on the buccal there, it's going to push that tissue coronally over time.
Since time is on our side, and
yes.
Something I explain to residents all the time as well is that, I like to see the case, photograph it, discuss with the restorative dentist, maybe take a little bit more off the distal line angle of number 9, mesial line angle of number 10, allow the papilla to keep coming down, because it could take months, it could take even years for those papillas to fill in to these areas. So what are your thoughts on this? Because this is a pontic, but it's a different type of pontic because the tooth is still there. So that bone is there where it was, right? On the mesial of number 10.
Yeah.
I mean, this is a very interesting case.
So adjusting provisionals is one of those things that most dentists hate to do. So, I'm an oral surgeon. You're a periodontist. We work with referrals. Anytime we send patients back and ask them to adjust provisionals, that's a chance for them to unscrew the provisional and break it. And anytime you put an implant, as I said, deep to create vertical tissue, you're putting an implant connection inside the bone. So disconnecting, connecting can create a lot of issues. So I think this is where it's extremely important to work with a really good lab to give you the most ideal shape that you can. Now, as the tissue changes, yes, I will go in and adjust and add composite. That I think would take an all-day lecture to talk about how to manipulate these provisionals. I think, it took me at least 5, almost 10 years to figure out the nuances of how to do that. And I think that's the beauty of dentistry is that, it's art and manipulating this. So now I actually have to manipulate this to create the arc because too much tissue has come down and to sharpen that papilla in the middle. And so we do that. And anyway, and here you can see the x-rays. You see how the root is buried now underneath with bone, and where that peak of bone is actually covered in bone. This is 1 year later. You can see with the final restorations, Naoki took this photo. But, the nice thing about working with Naoki is he's able to get the patients back in and photograph all these patients. Beautiful. And you can see the result over time, the tissue settling in nicely, and the keratinized tissue in the beginning had no keratinized tissue, and you can see now with nice keratinized tissue formation.
The difference between pink porcelain here and not, as your case, is keeping that root.
Exactly. Yeah. And so that's why I picked these cases to illustrate, because I think to share with residents and clinicians doing this is I don't want, I work with my residents and I always tell them it's not just drilling a screw in. It's, that's the difference between a doctor and a technician is that, you have to think through every single case and you have to adjust the cases according to the needs of the patients. Yeah. And sometimes you are left with not perfect decision. The world isn't black and white. We don't have a good and a bad option. Sometimes it's a gray option. In this particular case, leaving, the root. There's a lot of compromises here.
Yeah.
And as I said in the beginning, most of these treatment, we're borrowing some time. There could be problems down the road. That's a screw retain restoration. I can always unscrew it. If I needed to remove the root, I can. But now there's bone around the implant, around the root. So my thought in all this is, I want to borrow some time. All treatment is in by nature somewhat transient. And but so far so good with this patient.
So, Bach, we got about 8 minutes left.
Yes.
Can you show another case?
Yeah.
And if there's any questions, please write them into the comment section, and then we'll try to answer that at the end. Then.
Yeah. Here's another case I'll show really quickly. Some of may have seen this. So here's a defect with missing papilla, high smile line, and I find moving tissue down vertically is very predictable using the incision that I showed. So here you can see the papilla is missing there. So my goal is to try to bring this tissue down vertically so that it doesn't necessarily have to match number 8, because number 8 is actually short. So number 8 actually can use a little bit lengthening, like crown lengthening or gingivectomy. So I go back to this incision, bringing the tissue down coronally. I would encourage everybody to try this incision, the open book flap. It allows you to bring down vertically. So I'll share with you here like an example of how we're able to do this. So here, this patient is missing 8, 9, and 10, and she's going to need an implant at 8 and 10. She's got a lot of recession on number 10, a lack of keratinized tissue there, and you can see that right here. So I make my vertical incision at the site of the open book flap. I overbulk the bone, and I cover with a membrane. And so now this incision allows me to vertically advance forward. So then I suture with that area exposed. So it's the same concept. So most of these cases have the similar concept. So you can see how the bone that I put goes all the way clear up to the floor of the nose. So you can see how tight this is. It's not tension. I'm not suturing under tension, but it's tight because I don't want anything to move inside there. So when this heals, this is 2 weeks later, you can see the amount of bone that goes clear up to the floor of the nose. But this is why this incision is important, is that the bone cannot go anywhere except coronally. So you see how it goes more coronal. And so this allows me to put the 2 implants in. So when I put the implant, of course, I put some more bone graft. And then I go and uncover this implant. And this is how I uncover all my implants, is I don't make an incision. I make a nick in the gum, and I pop the cover screw out. There's never an incision. Then I screw in a larger healing abutment, so it doesn't disturb the soft tissue.
Yeah, I call it a keyhole incision.
Exactly.
Yeah.
And you can do that with a little spoon excavator. So anyways, on the day of delivery, this patient came from out of town. I didn't deliver this crown. Then Naoki didn't do this case, so the restoration is not that aesthetic. It's not. I didn't show this for aesthetic. I just showed you that you can coronally reposition this. So going back to our other case here, this incision design that I use is the same here, open book incision. See, here's the vertical. I did a little crown lengthening here to shorten that tooth. And then I put the allograft, and I can bring that down to match the other side fairly predictably on a single tooth. And so now you can see where I sutured it. It's a little high, but if you wait, you see it comes down. Yeah. All of these, it comes down. And then when it comes out, I place the implant flapless. I told you, I always place this flapless. I'm not too concerned about that short papilla in the beginning. I place this implant towards the cingulum, deep enough to create vertical thickness, and towards the cingulum to create horizontal thickness. I trim the tissue a little bit more. So you can see I'm calibrating. I'm not doing everything at one time. I trim a little bit more to even things out. And then my dentist puts a provisional on it. Still a short papilla. And then this case, we sent to Gianmarco O'Brien, who did the first case. And you can see he's going to adjust the provisional. And this is the out of the paper by WHO, where they we under contour this provisional in the beginning to allow tissue to fill in the bulk here. And then after, I think, about 4 to 5 months, when the tissue is filled in, what Gianmarco does is he overbulks the provisional to displace that tissue into this point. Now, it's not growing papilla. It's just to sharpen this little point here. And so you can see there's the line where you drew it. And then he adds there's the bulk that he added to essentially create that little sharpness. And so now, and then we do a little more gingivectomy. So you can see here, there's nothing done at one time. Everything is just done, very slowly. And there's that little bulk we added. There's the thickness of the soft tissue by our implant positioning. And there's a keratinized tissue. And Naoki makes our restoration. That papilla is exactly where it was from the beginning with the patient. So you can see, with that incision design, it's you're able to bring this down vertically. I didn't really want to show these really severe cases because I don't think that's really the point here. The point here in this talk here is just to illustrate that all the cases that I've shown, you can see that, my transformation as an oral surgeon to becoming, a more multidisciplinary dentist, right? Learning perio, learning pros, and really combining that. And as part of this team, I think it was somebody said it, but when you're part of a team, you really have to know, what everybody else is doing at the same level that they're doing at, so that you're not the weak link in the system. So I don't want to be the oral surgeon not knowing pros or perio. So all of these cases, what I've learned is that I've learned to slow everything down. And it's really helped to benefit me in my practice significantly. And if there's anything I could share with any dentist out there, is that, time is your friend. These cases, when we're working in the aesthetic zone,
take your time.
Take your time. There's no hurry. Yeah.
All right. Got a question for you.
Yeah.
For the audience. What type of membrane you use to allow it to be exposed to let the tissue granulate in?
So the membrane that I used in the first few cases is what's called an Ostrow Plus.
Yep.
So it's cross-linked using a sugar essentially. So traditional membranes are processed or cross-linked different. I like a cross-linked membrane because it tends to stay longer, and because it's when it stays longer, it does not break down the amylase in the saliva. It doesn't break it in the saliva. Doesn't break it down quickly. For example, a non-cross-linking membrane, leaving it exposed for 2-3 days, would be gone. So this type of membrane can left exposed slightly, not completely exposed, but like you saw in the pictures, and it's biocompatible. So the tissue can granulate over these areas, and allow for keratinized tissue to grow in these areas.
Bach, I want to say thank you so much for joining us on our fourth AO hot seat. We have our fifth one coming up with Dr. William Giannola, our dean at Harvard University. And it's going to be a little different format than we did tonight. It'll be really discussions about building leadership as well as expanding clinical frontiers. So it'll be really a couple of areas that we'll be talking about. My co-host will be Lorenzo Tavelli from Harvard as well. So Bach, thank you so much. I want to thank the audience for attending. This will be taped on YouTube, so you're welcome to visit this in the future. And I say until Wednesday, September 25th, everybody have a great summer. And Bach, again, thank you very much.
Thank you so much, Bob. It's really an honor.